You're on mute, Alice.
Hello, everybody. Welcome to the Indie Sage Friday briefing. And today we're returning to the traditional Friday briefing format. That's not the one where I start the meeting muted. It's the one where we start with an update on the latest facts and figures. And then we focus for the rest of the session on questions from you, the public. From vaccination and boosters to mitigations in schools, what are they? We want to discuss questions that are important to you. The government has been advised by its own scientific advisory group to introduce mitigations and bring in the so-called Plan B. That was a couple of weeks ago, but it's continuing to ignore that advice, even as we approach the difficult winter months. And this week, a senior member of SAGE quit that committee. So we have a government that is not taking enough mitigation measures and is out of step, which is what's happening across the rest of Europe. And winter is coming. It's more vital than ever that the public has direct access to scientific information and to be able to get their own voices heard in the debate. So that's why we today are returning to this format where you, the public, are driving the conversation. Before we launch into the Q&A session, Professor Christina Pargel is here to present the latest numbers and trends. Christina, over to you.
Hi, everybody. So last week, I promised you that you would get a full number session today, and that's exactly what we're doing. There's a lot to cover. There's a lot happening. So I'll try not to be too long, but there is a lot to talk about. And I think that you'll see that there are kind of consistent themes throughout that kind of all coming together to explain the current situation. So I'm going to start with cases, go on to the React study to dig in a bit more to those cases, then move on to hospitalizations, vaccinations, a little bit about the new variant that's under investigation now by the UK Health Security Agency, and then a little bit on the international perspective. So firstly, before we actually look at cases, I just want to look at testing. This is England, where the brown line is lateral flow test, so the rapid test that you can do at home, and blue is the PCR, and you can see that there was a distinct half-term dip in lateral flow device tests last week. So just bear that in mind when we're looking at tests, that there was a reduction in testing and a reduction in PCR tests. And sure enough, when half-term, and this is England's half-term, started at this red line, there was a reduction in reported cases last week. And also this week, it's kind of flattish. If we look at it by home nation, by data test, so this is up to Halloween, 31st of October, you can see these kind of drops at the beginning of half-term and then a bit flatter later. But if we look at it by positivity rates, which takes into account the drop in testing, you can see that actually the only country that has a reduction in positivity rate is Northern Ireland. Scotland and England were completely flat, and Wales actually started going up. So that's kind of telling you that, you know, certainly maybe some of the reduction was real, but not all of it. If we look at it by age group now, 2 weeks ago, I showed this plot, which went up to the 17th of October, and I said that we would see rates in school children fall over half term, partly because of lack of testing, but also hopefully because it is breaking chains of transmission, and hopefully teen vaccination will start having an impact. And what we've seen since half term is we have seen quite a steep drop in rates in 10 to 14-year-olds that actually started in the week just before half term. So that's really good news. And we're seeing it in 5 to 9-year-olds and 15 to 19-year-olds too. And we are now seeing this as well in the ONS infection survey. So it looks like for now, cases in school-age children might have peaked, but we don't yet know what's going to happen now they're back in school, whether that's going to pick up again. But cases in adults have not dropped, they've gone flat. So certainly in terms of impact hospitalizations and stuff, this will not be feeding through into the NHS yet. And then the React study is a study by Imperial College. They randomly test thousands of people every month, and they just released on yesterday their latest half round, which is why it's 15A, where a test of 67,000 people. And they're comparing it to the test they did on 100,000 people a month earlier. And what this is really good for is it completely gets rid of testing behavior. And so you can really kind of look at what are the differences in those 4 weeks. So this is looking at it by region. So orange is the most recent, the end of October, and yellow is September. And you can see every single region in England has increased a lot over that time. And the biggest increase by far is in the southwest. And in fact, the southwest rates increased almost fourfold in those 4 weeks. And that is really almost certainly exacerbated by the Immensa lab scandal, where you had 43,000 people told they didn't have COVID when in fact they did. And this is looking at it by age group. So the first thing to say is, first of all, these are different age ranges to the ONS infection survey. So this is kind of secondary school cohort, and it includes 16 and 17-year-olds, who about half of whom have been vaccinated. So that's slightly lower than the ONS estimate because it includes those people. And then for primary school children, it only includes school-age children, whereas ONS goes down to age 2. So this is slightly higher than the ONS infection survey. But you can see that both in primary school and secondary school children, case rates are really, really high in October, and more than twice as high as they were in September. So kind of confirming what we've seen in the cases and in ONS. But those increases are across pretty much all age groups, particularly parental age groups, and actually even now the oldest age groups. So cases in 75-year-olds and older have also more than doubled in those 4 weeks. And in fact, the REACT study team ended by saying that what they think we're seeing is a big surge driven by children, unvaccinated children in school, that's moving up through the generations and actually putting vulnerable older adults at risk. And they could break down their results by households that had no children on the left and households that had at least one child on the right. And you can see that although everyone increased, the increase was larger in households that had at least one child, and also much higher prevalence in households that have at least one child. The other quite interesting thing here is the gradient by deprivation. So pretty much for the very first time in the pandemic, prevalence is highest in the least deprived groups. And the differences between deprivation quintiles is also the least it's ever been. And this really seems to be because this particular surge is driven by children catching it in school. And in a sense, the people who have been most protected during the pandemic by being able to work from home, by living in kind of spacious housing and so on, are no longer really in a position to protect themselves if they have school children. And also they have lower rates of previous infection. And so in that case, also a little bit more vulnerable. And so what we're seeing now is almost kind of an equalizing effect because the current surge is driven through schools. And this isn't about testing. We can see this in the case data as well, but there's a question of, you know, is there the least deprived people are more likely to get their children tested, for instance? But this is taking out testing behaviours, randomly sample people, and we can still see this effect. I just want to say something about long COVID. So the ONS releases estimates once a month of people who self-reported long COVID. And they do it by people who say they've had symptoms lasting for 4 weeks and people saying they've had them lasting for more than 12 weeks. Now, ideally, you'd use more than 12 weeks, but because we want to look at the effect of the recent surges, I'm using the 4-week data, because otherwise we can't look at anything that happened since June, really. And so what they do is they report at the beginning of the month of people they asked the month before. And because you have to have reported symptoms for at least 4 weeks, as people who got infected the month before that. So this is looking at the percentage of all people per age group, so going from secondary school children all the way up to kind of older adults who are reporting symptoms for at least 4 weeks after their initial infection. And the light coloured bars are people who were infected before May, and the dark colour is people who were infected before September. So it's the last 5 months of reporting. And what you can see is this big increase here in the 17 to 24-year-olds over the last couple of months. And this is really reflecting the large number of infections in young adults over July and August of this year. We also see quite a big increase in the 12 to 16-year-olds, and this actually is likely reflecting the surge that we saw in schools at the end of July. But these are people infected before September. So we have not yet seen the impact of the really big spike that we've seen in children this autumn. And so unfortunately, I suspect over the next few months, we are going to see this chart grow. And to be honest, I find that really quite sad. What would be quite interesting is to see how much it grows in the older adults, because these are primarily vaccinated people. So we don't yet quite know how much difference vaccination makes on the chance of you getting long COVID. Looking at hospitalizations and deaths now, this is the number of people in hospital per million people for each home nation up to the 4th of November. And apart from Northern Ireland, which is quite flat, but still very high, it's going up in every nation and going up really steeply in Wales. And that's reflecting the fact that they've had quite steep case increases in early October and mid-October. In looking at hospital admissions in England, you can see there was a kind of a dip in September, and then as cases kind of moved from children into older groups, it's been going back up, and it's now higher than it's really been since February and March, and staying high. Now, boosters should have an impact on this. The question is how quickly we can boost and whether we can outpace infection. And the other thing is that it's not just hospital admissions. If we look at the number of people in mechanically ventilated beds, so these are the very sickest COVID patients in the UK nations, you can see that every single country is seeing an increase in people needing mechanical support, mechanical ventilation support. And although, yes, these rates are much lower than they were in the winter wave, it's still causing a significant burden. So if we just look at critical care capacity, this is adult critical care capacity. This is the, out of all people in critical care in England by region in the 1st of May. So this is before we really had the summer surge, and we were still at 1,000 to 2,000 cases a day. You can see that actually COVID patients made up a minority of patients in critical care. And in London, it was the highest, and it was about 10%. If we look at it now, so this is the 4th of November, you can see it's massively changed. So apart from the Southeast, every region has at least a quarter of critical care patients right now being COVID patients. And the Northeast and Yorkshire and the east of England, it's about a third of patients have COVID. Now that is creating a massive burden on intensive care. And particularly it means that you cannot deliver the way you'd want to, for instance, elective surgeries where people might need an intensive care bed to recover. If we look at deaths, this is a number reported across the UK to the 4th of November. It's been going up, sadly, and this is again reflecting the fact that cases have been moving into older adults, but also the vaccine efficacy has been waning. So boosters will help, but they haven't got there yet. So we've been recording over 1,000 deaths a week in the UK for the last 2 weeks. And again, most of those are directly because of COVID. And then I wanted to show you this table. This comes out of the UK Health Security Agency weekly vaccine surveillance report. This is from yesterday's report, and it's looking at the number of deaths within 60 days of a positive COVID test by date of death. And it's basically for the 4 weeks in the middle of October. This right-hand column are people who were fully vaccinated before they caught COVID. And if you just look at the last 2 rows, these are the over 70s. This is the number of deaths. And so basically almost 2,500 fully vaccinated people over 70 died with COVID in those 4 October weeks. And that is a consequence of high community cases and some vaccine waning. Without vaccination, we would have far, far, far more deaths than we're seeing now. There's no doubt about it. This is not saying that vaccines don't work. They do work. What it is saying is that if you are trying to live with the high level of COVID cases that we are trying to do right now, people will die. And we're seeing fully vaccinated, vulnerable people are dying because of the high rates that we're trying to live with. And I think this is particularly sad as we're currently trying to boost people, because the boosters will help massively. So let's have a look at the vaccination data. This is the kind of vaccination status by home nation, by unvaccinated, 1 dose, 2 doses, and boosted. You can see that really England, Scotland, and Wales are pretty similar. Northern Ireland is really lagging behind in its entire vaccine programme, but particularly its booster programme. If we look at teenage vaccination, Northern Ireland doesn't have this data, it doesn't make it available, but you can see that England is continuing to lag behind Scotland and Wales. So we've only given about a quarter of 12 to 15-year-olds 1 dose compared to over half in Scotland and Wales. Now, I was hoping to see a much bigger uptake over half term, but we've really gone from about 21% to 27% over half term. So unfortunately, we're going back to school now, and we still haven't really vaccinated most of our teenagers. And the other quite worrying thing is that there's a really big deprivation gradient in teenage uptake. So this is looking at 12 to 17-year-olds, so it includes 16 and 17-year-olds who were vaccinated in August and September. But you can see that, only a quarter of 12 to 17-year-olds in the most deprived areas have had 1 dose, compared to almost half in the least deprived areas. And I think this is something that we do really have to address, because we know that COVID is really disruptive to education. And we know that if you are living in a deprived community, you're already more at risk from hospitalisation and long COVID, and we're not protecting those communities. And I don't know how much impact the kind of rampant vaccine misinformation that's been targeted at schools and school children is preventing uptake in more deprived areas particularly. And this deprivation gradient in teenage uptake is much more severe than the deprivation gradient you get in adults and their first dose, although that's definitely there and it's still a worry. It's much less of an effect than it is for teenagers. Looking at boosters, this is England now. And you can see that we have given about 2/3 of over 75s a booster, and almost half of over 70s. Now that looks like we're doing really well, but what you have to remember is that almost all of this population received their second dose over 6 months ago. So they're eligible and haven't had it yet. So if we look at it by when you were eligible for your dose, you can see that although we are boosting, we still have a really wide gap between people when they become eligible. So about 13 million people have now had their second dose 6 months ago, and about 6 million of them still haven't had that booster dose. So we've only actually vaccinated about 55% of those who received their second dose. And that's because we did really well in rolling out the initial vaccines. We really, really did well, but we're not doing as well in rolling out the booster. And so you can just see this quite easily if you look at the daily numbers. Yes, we're, boosting maybe, 250, 300,000 people a day, but we were giving jabs to 500,000 people a day in the spring and the winter. And as these people become eligible, we're going to have to up this. If we really want our booster program to save Christmas, we're going to have to do it a hell of a lot quicker, because at the moment, we're not going to get through the people that should be getting it before next year. A quick bit on variants. There's been a new variant in the news. It's called AY4.2. And what that is, so essentially there's Delta, which kind of became dominant in May. Delta's got lots of little subtypes. It's got lots of little Delta children. They all start with AY. The most common Delta child in the UK is called AY.4, and it has now got its own child called AY.4.2. So this is like the Delta grandchild. And it's the first kind of Delta subtype that looks like it actually can spread faster than Delta. And it's been growing in the UK since about end of July. So this is from COG data, and you can see it kind of starts here and it starts really growing in August. And it's somewhere between 15 and 20%. It's highest in Scotland and lowest in England. Well, actually, it's lowest in Northern Ireland, where it's hardly there at all. But out of mainland UK, it's lowest in England. And if we just look at the English data that can go up to the 23rd of October, you can see here it's this red band that's been slowly growing since August. So it looks like it does have a transmission advantage. The UK Health Security Agency is now tracking it as a variant under investigation. They estimate it's got maybe a 15% week-on-week growth advantage over Delta, other Delta types. It doesn't seem to have any different response to the vaccines, so that's good news. But with that kind of growth advantage, it might become dominant by mid-January in the UK, and it might then be almost all cases of COVID by about mid-February, assuming that no new variant comes along. So it's growing much slower than Delta versus Alpha. So Delta became dominant in 8 weeks. It's going to take AY.4.2, maybe 6 months. And so you can see, like, it's not a good thing. It's going to make everything a little bit harder because it's a little bit more infectious, but it's not the game changer that Delta was or that Alpha was back last December. And just in terms of regions, it's growing in every region. It's highest kind of in the southeast and southwest, and lowest in the northeast. And I just want to highlight one of the big concerns to me about this variant isn't so much the fact that it's there. I mean, as I said, it's going to make things more difficult, but it's not going to make things disastrous. But it's that it shows that COVID is continuing to mutate. It's continuing to mutate a lot. Sage Minutes from the 14th of October said there should be no complacency around the risk posed by further viral evolution. There's no reason to think that COVID has got to its end point. It has not. And minutes from last week, from the 29th of October, said that they're still concerned about a new variant with partial vaccine escape properties. And they actually say specifically that very high prevalence in schools combined with partly vaccinated 12 to 16-year-olds in a highly mixing population provides ideal conditions for vaccine escape emergence. So the fact that we're still doing this here in the UK, where we're trying to have really high COVID rates, everything open, partially vaccinated populations, we're not vaccinating teenagers fast enough. We're just allowing opportunities for Delta to get worse. And I just want to kind of finish with an international perspective. We haven't touched on that for a while. And last time we looked, we were kind of saying, well, you know, Europe's doing a lot better than the UK. So that has changed a bit. What we're seeing is that basically Eastern Europe is going through a really serious surge in COVID. So these are case rates in the UK. Just I've put the UK in all these plots for comparison. And these are different countries in Eastern Europe. This is Slovenia is at the top, and Hungary is at the bottom. And not only do they have really high cases, they also have really high deaths. So in terms of deaths, the UK is far lower than the rest of these countries, particularly Romania and Bulgaria. And what the problem with Eastern Europe is they just haven't vaccinated. And in fact, Bulgaria and Romania have, 20 to 30% of the population is fully vaccinated. That's not enough. And it's causing them massive, massive issues as we go into winter. And they're seeing some of the highest mortality rates that they've seen throughout the whole pandemic. And it is a real tragedy because they have access to vaccines. They just haven't managed to get people vaccinated. Then there are other countries like Austria, Belgium, Denmark, Germany, the Netherlands, who were doing pretty well all summer with much lower case rates in the UK and have started to surge in the last month. You can see these kind of consistently steep increases. And that is mainly because a lot of these countries have actually stopped doing any other measures. They kind of moved from vaccine plus to just vaccine. Now, they're all about equally vaccinated as us. And so you can see that actually in terms of deaths, the UK is still the highest. But I imagine that many of these countries will catch the UK up, particularly maybe Austria and Germany, who have lower vaccination rates in the older population. But you can see just how difficult it is to move from vaccine plus to vaccine and keep cases under control. And then you have other countries who did well over the summer and are still doing pretty well. This is France, Italy, Portugal, Spain, Finland have far fewer cases than us, far fewer deaths than us. They also all more vaccinated than us, particularly Portugal and Spain. But that's not all. They still have other mitigations. They're still doing vaccine plus. Now, all countries, I think, will struggle a bit as we go into winter, particularly countries who will start having vaccine waning come into play, because they obviously vaccinated a bit later than us. So vaccine waning will happen a bit later than for us. But nonetheless, they are currently still doing pretty well in managing COVID. The other big international thing that happened this week is that the US has authorized the use of Pfizer in 5 to 11-year-olds, so a third of the adult dose, not the full dose, and has started that vaccination campaign. And what the CDC said in its press release announcing this is they highlighted, that COVID cases in children can result in hospitalizations, they can result in deaths, it can result in what they call MIS-C and we call PMCS, but the kind of pediatric inflammatory syndrome that often ends up with children having to spend some time in intensive care. And also they explicitly talk about long COVID, where children can get that even 5 to 11. They also discuss how the Delta variant resulted in a massive surge of cases in children throughout the summer, and the hospitalizations in children increased 5-fold over that time. And they said, vaccination can protect children from COVID-19 and it's safe. They also actually interestingly emphasize that it's vaccination along with other preventative measures. So, the CDC has always been very clear, especially for children mixing in schools, you need vaccination alongside other mitigations in schools. They kind of compared it to other common childhood diseases that are routinely vaccinated against. They're not quite the same as in the UK. So in the UK, we don't routinely vaccinate against hepatitis A, I think, or varicella, which is chickenpox. But they compare the annual average deaths per year just before the vaccination programs are brought into COVID, and you can see that COVID had by far the highest deaths in 5 to 11-year-olds for all of these other diseases that children are commonly vaccinated against. And they also said, it seems very effective. This third, the smaller dose is still 90% effective at preventing COVID in children ages 5 to 11. And then finally, as we're talking about vaccination, there's still these massive vaccination inequalities globally. When we did the G7 in June in Cornwall, we were trying to get promises to try and tackle this. Nothing really seems to have changed. And as an international community, we could produce more vaccine, we could donate more vaccine, we could support other countries to produce more, we could support other countries to distribute it more. And we're just not doing enough on that. And you can see, particularly in Africa, very, very few people have been fully vaccinated. So, summarising, the most recent fall in cases is likely due to kind of reduced testing and falls in school-aged children. We don't yet know what's going to happen on the return to school. It will take 2 or 3 weeks really for us to work that out. In England, vaccination, I don't think is high enough yet, but obviously we do have these really high levels of infection now from the first half of term. Hospitalizations and intensive care use are both rising, and the NHS situation is getting worse. So this is a tweet from today highlighting an article about Addenbrooke's Hospital in Cambridge, which is one of the premier teaching hospitals in England. And the CEO said, it's ceasing to function as a hospital. Hospitals are incredibly strained, and that's only getting worse right now. Deaths are also rising. We just need to vaccinate faster. We need to vaccinate children, both to protect children and to prevent transmission. And we have to vaccinate older adults to prevent really severe outcomes. And we need to address the gaps by deprivation and ethnicity. I think, the European picture shows you need really high vaccination rates and you need some other measures. And the countries that are trying to do without other measures are struggling. The global picture shows we're still not doing nearly enough to ensure global vaccine equity. COVID is continuing to mutate and the threat of a new variant remains really high. And really, in the UK, more people are getting very sick and dying. More and more young people are reporting long COVID after the high infection rates over the summer. Children's education was disrupted in the first half of last term. We know from ONS that teachers were more likely than other adults to get sick. We just need to get cases under control now. We cannot rely on a vaccination program to do it all. And a vaccine plus approach will help. We don't need cases to be climbing to 100,000 for that to help. Whatever we do, whether they fall, whether they stay the same, if we do vaccine plus, they will fall quicker and we'll get it under control quicker. And I just think that's what we need to do. And I will end there.
Thank you very much indeed, Christina, for that very clear presentation of all the facts and figures, and also those comparisons with international situations as well. It's very useful indeed. Right, I'm going to start with a question from a member of the public, Melissa Brantsberg. Melissa, are you there with us on the call, and what is your question?
Hello. Hi, thank you everyone for taking the time. So I'm a mom to 3 kids under 12, and I was just wondering about your opinion on vaccinating the 5 to 11-year-olds. As Christina just said, that the US is now vaccinating them, and when I asked this question on the panel over the summer, it seemed hesitant about whether there was enough benefit for kids. But given the UK government policy and current COVID levels, I was just wondering if everyone has changed their mind and if potentially 5 to 11-year-olds should be vaccinated. And I'm just worried that the UK is not going to offer it here. So I'd like to hear your thoughts on that. Thank you.
Thank you very much, Melissa. Thank you. I mean, certainly the UK really dragged its feet over vaccinating teens. What do we think is going to happen? And should we be vaccinating 5 to 11-year-olds? Christina, straight back to you.
So just on this, so me, some other people in this age and some other people did a risk-benefit analysis in adolescents over the summer. And it became really clear that if you got to really high case rates, it's massively beneficial. And so even though children at 5 to 11 are less likely than adolescents to get really sick, at the current rates of infection, with 6% infected at the end of October, it's almost certain to be beneficial. And the CDC had a really good presentation, and they actually go through quite how beneficial it is, even if you already had COVID as a child. So I would be very surprised if there wasn't a benefit to vaccinating 5 to 11-year-olds. I'm a bit concerned by the fact that some members of JCVI are already saying it's too soon.
Thank you very much, Christina. Professor Deenan Pillay, I wonder if I could bring you in on this particular question about vaccinating younger children.
Well, I very much agree with Christina and Melissa. I think what's happened since that time when you asked us the question previously is, of course, there's been a number of trials, and we're always concerned about untoward effect of all medicines in children, and of course we can't just extrapolate from data that comes from adults to children. We've got to wait to ensure that there's safety in children, and now that's happened. And as Christina mentioned, not only the FDA, the Food and Drug Administration, which is the regulator in the US, has approved this, but now the Centers for Disease Control, who are the sort of more public health structures in the US, have come out very clearly about the advantages of this. So not only for children, again, as Christina has said on this time and on multiple occasions, we've discussed that children are also now very clearly infection in schools also drive infections in adults who are more vulnerable, particularly elderly, and that's come out of the REACT study. So there are multiple benefits of immunizing children, not only for themselves, but also for the community, and therefore contributing to keeping infection rates down. And for all of those reasons, I'm pretty surprised and shocked that the UK seems to be lagging behind much of the world in this, and I would urge the UK, JCVI and other structures to really consider the data that are now come out in children.
Thank you very much, Deenan. I would like to bring in Anthony Costello as well on this particular answer. And I don't usually give people a rundown of all the expertise here on the panel. That is all there on the Independent Sage website. You can see biographies of everybody. But Anthony Costello is a paediatrician and was Director of Maternal, Child and Adolescent Health at the World Health Organization between 2015 and 2018. So I think your perspective would be very welcome here, Anthony.
Well, just to endorse what Deenan and Christina have said, we know from the CDC figures that deaths are higher in children from this vaccine preventable disease than others. So, okay, it's a low risk. Hospitalization, likewise. The one I always think about is long COVID. We think that 1 in 7 children get long COVID symptoms. We don't know how long COVID is. We don't know the long-term effects on T cells as well. But I better stop now because you're going to hear background from the climate conference.
Thank you very much, Anthony, live from the climate conference in Glasgow. And thank you very much for that question, Melissa. Moving on now to a question from a member of the press who's here this afternoon, Catherine Lough from TES. Catherine, what's your question?
Hello, thank you. So I just wanted to ask a little bit more about the data about how deprivation impacts the take-up of pupil vaccination and why that's different for young people compared with adults. And the other thing I wanted to ask was what the views are of Indy Sage in the idea of a triple lock so that school closures can be prevented in the future as well as was mooted this week.
Catherine, you've snuck in 2 questions there. Let's start with the first one, which was about why we think vaccination uptake is lower in areas with socioeconomic deprivation. Dr. Zubaida Haque, could I ask you to start with that question?
Thank you.
Oh, I think, Zubaida, we can't hear you. It doesn't look like you're muted. But we can't hear you.
Can you hear me now?
Yes, we can. Go ahead.
Sorry, I was trying a speaker. I was going to say, Catherine, you're absolutely right. No, there's several concerns here. One, of course, is that the vaccine uptake among teenagers is much lower in deprived areas, but that also reflects the adult vaccinations in deprived areas as well as vaccination uptakes by some of the Black and Asian groups. I think the issue is it's quite complicated. It's certainly not all to do with vaccine being anti-vax. Most of it, I think, is to do with vaccine hesitancy. And one of the issues that's been plaguing us that this government hasn't dealt with properly is why are people not taking up the vaccines? And we know from previous research that there's issues around nervousness, anxieties about the vaccine. There's issues around access. We constantly have heard talk from this government about taking the vaccines to people. But have they really done that? Have they really resourced local providers to take vaccines to people? And of course, there's been not much research about why there's more vaccine hesitancy among teenagers and among some of those groups. It is concerning because, of course, we know that Black and ethnic minority groups are much more exposed to this virus. We know that people in deprived areas are much more exposed to this virus because of where they live, because of the type of work they do, because of the overcrowded housing that they live in. And this government has done very little to address that. So I think I am very concerned. And in terms of teenage rollouts, we do need to think about the impact of teenagers in deprived areas where they are much more exposed.
Thank you very much indeed. And also, can we then just focus quickly on that triple lock idea, which was, I think, with the idea that education and in-person education is really incredibly important to children, and that schools should only shut as a last resort, which I think has only ever happened. But what is the kind of tension now between public health and education on the other hand? Who would like to take that second part of the question? I'm going to pick on somebody if I don't get somebody. Professor Susan Mickey.
Hello. Well, I don't think there is a tension because the more that public health measures are taken in schools, ventilating schools and where ventilation is impossible, ensuring there's air filtration, asking school students to wear masks when they're indoors, the more these kind of measures are taken, then the lower the cases at school, and the more that the schools will remain open. In addition to those general ones, there's also measures that can be taken in terms of going back to the bubble idea, whereby if somebody's infected, then the people immediately around that child is at home until the infection risk is over. And also, if people are infected, then there's some contact tracing going on. At the moment, what happens is if a child is infected or their parents, family members are infected, other children at school won't necessarily know. Whereas there should be contact tracing. There's good evidence that that's effective. So really, we want to bring back a package of measures, public health measures, that will keep schools open and keep children at school. So they're not in tension, they go together.
So the mitigations in schools seems to be the crucial missing piece of the jigsaw, doesn't it? That, you know, at the moment we seem to be talking about either keeping schools open with no mitigations or putting ourselves in a situation where children are absent. I mean, we know that thousands of children are absent from school at the moment. Anybody else want to come in on that question of schools and mitigations? Professor Martin McKee.
Yeah, well, I think we're also referring to the proposed bill that might go through Parliament, that's being looked at in Parliament, which would require a parliamentary vote to close schools. And this really seems rather strange, because one would have thought that it would be better that these decisions would be made at a local level. I think Parliament has quite enough things to be getting on with at the minute without debating every individual potential school closure. But as others have said, this has always been a last resort, and the emphasis should be on keeping COVID out of schools.
Thank you very much indeed, Martin. And Catherine, thank you very much for those questions. I know that Nigel Nelson's here as well. So Nigel Nelson, have you got a question for us?
Yeah, thanks, Alice. This is on boosters. Does immunity wane more with age, or does it wane equally with everyone after 6 months? And if that's the case, is there a point where double vaccinations become ineffective?
Thank you very much, Nigel. Really good question there. Quite a mechanistic question. Who would like to answer that? Who would like to have a go at that? Deenan, maybe?
Thanks. Hi, Nigel. The data are there on different differential waning patterns, but I can't. I'm struggling. Maybe one of my colleagues, I'm sure, will be able to contribute. But I think one of the problems with waning, we know that the longer the time from your double vaccination, the more risk you are of getting infected. I think there's good data from Israel where around that. So we know that that's generally the true. Having said that, I think it's also clear that even after a duration of time from vaccine, the risk of disease remains much lower than the risk in those who are unvaccinated. And of course, we also expect antibody levels to decline after vaccine. That's what happens normally. And of course, it doesn't mean that your immune system cannot then respond to new exposures. So I don't think we're going to get to a situation where the vaccines become ineffective after time, but it's a question of the degree. And as Christina again has said, it remains the case that the disease rates are much lower. Nevertheless, of course, boosters we know are useful. And looking to the future, I'm sure we'll move into a situation of having annual boosters in the same way that we do, whether those boosters against the same virus or against variants of the virus in the same way we do with influenza. Thanks.
Thank you very much, Dean. And has anybody else got a perspective here? Oh, yes, Dr. Helen Salisbury.
Hello. Really just to say that there's some nuance in that as well. It depends which vaccines you had. I think there is some difference between the people who had the Pfizer vaccine. It might be the AstraZeneca might be waning a little bit more quickly. And it's true that people who are getting the illness now, having had 2 doses, but now it's 5 or 6 months since then, are having positive results, but a lot of them are not nearly as sick as they would have been otherwise. And that's really important. I mean, it's bad that they're getting it because more cases mean more opportunities for the virus to mutate and more spread to the potentially unvaccinated. But for those patients themselves, most of them are not being terribly, terribly ill, which is great. I think we do need to get on, because if we want to put a lid on this and stop this incredibly high rates we have at the moment, we've got to boost more effectively, because once they're boosted, they're very much less likely to catch it or pass it on. The booster program is rolling out slowly, much more slowly than we'd like to. And I think that's, to a large degree, is because general practices and primary care networks are much less involved this time round than they were in the spring. We all really pulled out the stops to do the initial vaccine rollout. Everyone is feeling very much under the cosh, and a lot of practices have discovered they just don't have the staff to be involved this time, and it's not working quite so well at the mass vac centres as it did in the local primary care setups.
Thank you very much, Helen. So more resources needed, actually. Again, this is not an emergency situation anymore, is it? This is a situation which is going to recur and recur. So we can't expect people to be working flat out to do this. We need to increase resources. Thank you very much, Nigel, for your question. Nice to see you as always. And now I'm going to invite a question from Stephen Larkin. Now, Stephen, I know you have 2 questions. I'm afraid I'm going to limit you to 1 because I want to fit lots of people in today. So pick whichever one you want to ask the panel.
Right, thank you, Alice. Now that the Delta variant is dominant, it seems odd the booster campaign is using an original vaccine rather than a new one. So my question is, perhaps there's a worry about original antigenic sin or imprinting, in which antibodies are boosted against a previously encountered variant instead of antibodies being raised against the new variant. Am I right in thinking there was a trial about it in the summer, and do we know enough now about what to determine what exactly is the best approach? Thank you.
Thank you very much, Stephen. Original antigenic sin, that has to be a question for you, Deanan.
Yes, sinful. Thanks, Steve. Well, again, I'll other colleagues will comment on this. My sense of the data are that vaccines, albeit against the original Wuhan strain, that's what the vaccines are using as a way to generate antibodies, remain actually much more effective against other variants than I think we feared at the beginning. Remember, right at the beginning, as soon as it became clear that variants were evolving, there was a lot of talk about that boosters needed to be potentially with boosters against new variants. But in fact, that's gone slower in terms of development of those new vaccines. Having said that, the protection is damn good against Delta, for instance. So and it does seem again that vaccine-generated immunity seems to be quite broad in terms of activity against other variants. We've got to also separate between in a few months ago, before we had data from population studies, once large numbers of people been vaccinated, that much of the data was from laboratory studies, and there was their concern, if you remember at that time, that the antibodies may not be effective against other variants from laboratory studies. But I think what's been borne out is much more hopeful. So that's my sense, is that we're in a good place in terms of, and the key thing is getting those vaccines into people. Thanks.
Thank you very much, Dina. I mean, that's really good news, isn't it? Because it could have been very different. And we were very worried that vaccines would become obsolete quite quickly.
Absolutely, Alice. And now, clearly, and it's Helen mentioned this earlier, is that, of course, one of the weaknesses is as time from vaccine goes on, then infections can happen. And of course, that can fuel ongoing transmissions, even though morbidity and mortality, deaths are prevented. So there is a need to keep a watching brief on this. But of course, that is why we always say vaccines alone are not enough. We need to actually have a constellation of measures to reduce infection, of which vaccine is just one.
Thank you very much, Dina. That was a very comprehensive answer. Unless anybody else wants to contribute, I'm going to move on to the next question. Thank you very much for that question, Stephen. I'd now like to invite Elizabeth Evans to ask a question.
Hi. You've already said a lot about boosters, but I wondered if there is any data on the availability of boosters across the country. I'm on the Isle of Wight, and here it's really hard to get a booster. And if you want a third dose, then just forget it. The walk-in centres are only offering first and second vaccinations, but we have a lot of elderly people who are all there sitting, waiting for their GPs to contact them about their booster.
Thank you very much, Elizabeth. So is there a problem with booster availability? Does anybody know what the situation is out there with vaccines? Martin put his hand up, but maybe.
Well, maybe Helen would. Yeah, I mean, we're getting. I think the thing is we don't actually have the data. But one of the problems that that a lot of people seem to be facing, and I was thinking of letters to the newspapers that we've been reading, is the logistic challenges of getting to somewhere they can get a vaccine. I think one of the things we should remember in the first wave of the vaccine rollout, it was a success because of the enormous contribution of particularly primary care teams and stepping up to deliver the vaccine, and an army of volunteers who were delivering all of this. And that, I think, has somewhat dissipated. And now people are having to travel further distances. There are challenges of booking. And I think somebody really does need to look at this and understand what the challenges are that people are facing, because we're just getting too many accounts of it at the minute. But as I say, I think that's because we didn't fully appreciate the huge effort that so many individual people did put into the first rollout.
Thank you, Martin. And Helen, would you like to comment here, and then I'll come to Susan.
Yeah, I mean, I think it's really very difficult because there were no extra staff. And so most GP practices did it by everybody working lots of extra days, and there's only a limited amount of time you can do that. I think there's also an issue that for a lot of people, even if there is some availability locally, it's kind of hard. It's much easier when your own practice calls you and you go to your practice, you know where you're going, you're more likely to attend. If you have a letter from somewhere that you don't know, it's going to be more difficult to travel and you're less likely to go. So I think it's both it's a combination of a kind of hesitancy that's built from unfamiliarity and just lack of availability. And I don't have any map. I don't know when anyone's done a map of where things are available, where the constraints are, because I don't think we know. We just know there's a problem, and I'm really sorry. It sounds awful on the Isle of Wight to have so many people waiting, because a lot of those people must be well past their 6 months and beginning to feel quite unconfident about going out and mixing, knowing that their immunity may be waning. We do need to do something about this. I just don't know from the point of view of a GP. I mean, we are still doing them in my practice, but I can totally see why lots of GP practices aren't able to do that, and it needs to come more centrally.
Thank you very much, Helen. Susan, you wanted to comment too.
I was just going to make the point that it's not, there is the problem of resources, but also the accumulating waiting lists and pressure of patients with other things. So in terms of primary care being able to deliver, yes, more resources, but also recognising this huge backlog to get through.
Thank you very much. Thank you for all those answers, and thank you for that question, Elizabeth. And now we have Daniel. Daniel, are you there with us? Is he there? Daniel's 11. He's currently isolating at home, having caught COVID, and he's joining with his father, Duncan. Daniel and Duncan.
So my question,
there you are, Daniel. Yeah.
My question was, what are the variants of SARS-CoV-2 going to be called after we've had the Omega variant?
That's a very good question, because the Greek alphabet runs out then, doesn't it? And I don't know whether we just have to start again at the beginning. Does anybody have any idea? Once we get to 26, I mean, we seem to be doing, Delta 0.2.4 at the moment, rather than giving them all new Greek letters. Christina, do you know how it works? How will we start to name new variants?
I don't know how it works. I think when a variant becomes enough of its own thing, it gets given a name by the WHO. But I think the problem is now that almost all of the mutations are coming from Delta, like within Delta. And because there are just so many, there must be like 20 different subtypes of Delta running around now, of which AY.4.2 is just one. They're kind of hesitant to make one its own thing, because it actually is almost the same as Delta, just got a few mutations that are different. So I think, I don't know what they're going to do. I imagine they'll just start off with something else completely, or maybe they'll start naming them like storms. I don't know. I mean, who can say?
I think storms would be slightly friendlier than the numbers. And what do you think, Daniel? How do you think we should be naming them?
I think that, you know, Excel, after you get 99, you get like AA, AB. It might be like alpha, 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 beta.
Yeah, I think that's a good idea. Has anybody else got any contributions on in relation to Daniel's question, Professor Martin Mickey?
Well, I've just discovered that buried in the depth of the WHO documents is a suggestion they might be named after the constellations in the sky. So that seems to be what's being looked at, but I think we're a way off getting to there.
Thank you very much, Martin. And Helen?
I'm going to be really optimistic and say we're going to solve this problem before then. Okay, so we're going to get our vaccines sorted out all over the world, and we're going to have our mitigations in place, and we're going to get rid of COVID before we get past all the letters of the Greek alphabet. That's my hope.
That's brilliant. Thank you, Helen. Thank you very much, Daniel, for your question. And I hope that you're feeling better soon and back to school soon as well, and back with all your friends in school. Thank you very much for coming on today. It's lovely to have you on the briefing. We've got another question coming in here from John Hebden. John, are you there with us?
Yeah. Hi, Alice. Thanks very much. So my question is about the official reported cases data. Can the official reported cases data be trusted? I assume that this is the data that government look at most closely. It seems to be the most widely reported. And what prompted me to ask the question was that I was listening to the Imperial College Zoe briefing last week on the 28th of October, and Tim Spector was making the point that that the Zoe app is coming up with much higher rates of infection, twice the official government rates of infection. And he gave some reasons why that might be. He made a couple of comments about the way that the counting happens. He talked about symptoms, and he talked about less reporting of lateral flow tests. I just wondered if what Indisage thought about the official figures and how seriously we should take them, or are there better sources of data out there?
Thank you very much, John. Well, somebody who pores over the data every week. I mean, I know all of you do, but Christina does especially pore over the data. Christina, can I start with you?
Yeah, so I think you can trust it. I mean, there's certainly, I don't think there's any suggestion that the results are fiddled or anything. I mean, they do present positive tests. Now, where they are skewed, particularly in ways that say the Zoe app isn't, is people getting tested, and that relies on you recognizing that they're the symptoms of COVID, and we're way behind on updating people on what the symptoms are. They're actually much more like a cold than the kind of classic 3. Then people have to know that it's important to get tested, and then they have to be able to access the test, and then they have to be able to do something about getting a positive test. And all of those things mean people don't necessarily get tested. And I know Susan has lots more information about that. The other thing is that the Zoe app itself isn't necessarily that representative. It's definitely skewed more towards richer urban households, for instance. And you really have to look at all kinds of data. There's the official government data from tests, then there's the ONS infection survey, there's things like the React study, and we can look at all of those hospitalizations to get a picture of what's happening. And they are actually all broadly consistent about basically cases are really high and everything's getting a little bit worse.
Thank you very much, Christina. So each one, a slightly different sample, gives us a slightly different picture of the pandemic. Zubaida.
Well, I wanted to add also that the official tests rely on people actually being able to go and carry out those tests, to do those tests. And just this week, we heard that from last Monday, test centres for PCR tests are going to close at 6 p.m. So from last Monday, all PCR test centres have been closing from 6 p.m. Now, that's an extraordinary thing, considering we're in a third wave, considering we've had a month of surge in cases. We've seen how bad that is. And considering people have been encouraged to go back to work. So what happens if you're back to work and you're here in the office that you've been a close contact? How are you supposed to get a test after 6 p.m? What happens if your child comes home and you hear that they've been a close contact and you want to be a responsible parent? I know you can send them back to school at the moment, according to the government guidelines. But if you want to be a responsible adult, what happens after 6 p.m? You can't get any tests. So I think that needs to be turned around right now if the government actually wants to accurately know what the levels of coronavirus is in this country.
Thank you very much, Zubaida. Incredibly important point there. And John, thank you very much for your question as well. And that's it for today, folks. So we've covered a huge range of different topics today. Thank you very much for all the questions that have come in. Thank you to everybody watching, whether you're watching us live or on catch up. And having your questions is absolutely essential. They've driven the conversation today. So I also want to thank all the scientists of Independent Sage, and just remind everybody that all these scientists are volunteers here, and they're here because they think it's incredibly important that the public has access to independent scientific advice, and conversely, that scientists have the opportunity to listen to public concerns as well. All of Independent Sage's reports on various aspects of the pandemic are on the website, along with details, the biographies of all the scientists on the panel. Please follow Independent Sage on Twitter, and we'll be back same time, same place next Friday. In the meantime, stay safe, keep well. Bye-bye.
Thanks. Bye-bye.
Bye.